Hey, GLP-1 plus size community. Before we jump into the podcast, please take the time to leave us a 5-star review on whatever audio platform you're listening to the podcast on. Share your story and how the podcast has helped you. This will help us get referred up in the audio platform so that we can reach more people that need our help, our support, and guidance from our doctors. Help us get loud and change things.
Are you interested in understanding GLP-1 medications like Ozempic, Wegovy, or Mounjaro? Then join us on The Plus Sides, Cracking the Obesity Code, the groundbreaking podcast helping people change their lives one episode at a time. The Plus Sides podcast is a disruptor. We're breaking down barriers, smashing stereotypes, and sharing inspiring stories that'll leave you feeling informed and empowered. Join us every week to learn from doctors who are specialists around GLP-1 medications like Ozempic, Wegovy, or Mounjaro. They'll provide you with science and facts to validate these incredible stories. But that's not all. We'll also bring you the voices of the GLP-1 Mounjaro TikTok community, real people who face the challenges of obesity-related diseases and disorders and discovered the incredible plus sides of GLP-1 medications. Our episodes are filled with heartwarming stories, laughter, and moments of triumph. You'll connect with our amazing community members who are reclaiming their health and experiencing their fullest lives. Are you ready to embark on a journey of discovery and empowerment? Tune in to The Plus Sides, Cracking the Obesity Code, and together we'll change the narrative around obesity and end the stigma. Subscribe now on YouTube or your favorite podcast platform and join our incredible community. Let's celebrate the plus sides of life together because every story deserves to be heard. Every life deserves to shine, and everyone deserves access to expert knowledge and medication. The Plus Sides Podcast. You're not alone. It's not your fault.
Hey everyone, before we dive in, I really want to share something personal with you. About, I want to say like 8 to 10 months ago, after losing 100 pounds on GLP-1s and keeping it off for a long time, I started regaining out of nowhere, and I was terrified. But I also started having hot flashes and bouts of crying and snacky cravings and waking up at 3 a.m. unable to go back to sleep. It turns out I was in perimenopause. So I started hormone replacement therapy, which is also called HRT, through a telehealth called Winona that specializes in this. And it changed everything. And now I'm sleeping better and my hot flashes are all but gone, thank God. And I feel like myself again. And it turns out that you can actually start perimenopause as early as 35. And well, I'm 46 and she's here. HRT has really come a long way and there's just no need to suffer anymore. So if you're like this and you're in the same boat, you can check out buywinona.com and you can use the link in our link tree to save some money.
Want the fastest working GLP-1? For half the price, Ro now offers FDA-approved weight loss injections cheaper. With results you can see faster. Lose 15% of your weight with the formula from Eli Lilly that hits not one, but 2 hormones to curb hunger and nausea. Weight loss faster. Confidence higher. Price cheaper. See if you qualify at ro.co/TV.
Go ahead, Kat.
Well, we're going to, speaking of GLP-1s, I know that I work out with somebody who goes to a menopause like specialist, actually out here in Marietta, Georgia. But she is giving her practitioner is giving her a microdose of tirzepatide. They found out that she had, like, say, insulin resistance while they're treating her menopause. My question is, do you see that maybe potentially in the future, treating menopause and perimenopause, would there be a space for GLP-1s to
I think so.
Therapy? Okay.
I think so, because honestly, we're starting to see more research coming out that the two can actually have like what we call a synergistic effect, that they can positively affect each other. And there have been some studies that have been released recently in the last year or two that showing that women who are on a GLP-1, but also on hormone therapy actually are more successful in their weight loss and improving their overall metabolic profiles, improving their cardiovascular health compared to those women on GLP-1s alone or HRT alone. So, we're finding that there's very positive effects. And even women that are on GLP-1s can get some menopause relief just from that alone if they're not good candidates for hormones.
Yeah.
And that's something we could talk about too. Like,
Let's do
hormones
that.
are not safe for every patient, right?
Yes. Can we talk about that? Like, how do you know if it's
Absolutely.
for you or not, or maybe not?
Yeah. I mean, because I think the biggest reason why so many doctors have gotten away from being willing to prescribe is because there were some studies out in the past that really scared people away from hormones. And a lot of the research on hormone therapy years ago used much different doses, especially a lot of the hormones that were given were not bioidentical. You know, one of the first hormone replacement therapies that we had available was a medication called Premarin, which was derived from the pee of pregnant horses. And the actual name of the medication, Premarin, comes from pregnant mare's urine.
Oh, dear God.
So initially, those medications on the little package insert, it said it was conjugated equine estrogens. Well, horses have a hell of a lot more different types of estrogens than females. I told you we have 3 main estrogens as female humans.
Yes. Yep.
Female horses have a lot more. So those women that were taking those early drugs were taking all this extra estrogen that was based on horse physiology that wasn't even biologically active in their body. Like it couldn't have been good for them. But anyway. Yeah. So when you look at hormones, the biggest risk we worry about are blood clots. If you personally had a history of having a DVT or a deep venous thrombosis, which is a blood clot in the leg, or you've had a PE or what we call pulmonary embolus, which is when that blood clot somewhere in your body can then travel to your lung. It can be deadly, but if it's caught and treated with blood thinners, then, not necessarily. But if you've ever had a DVT or a PE, you really shouldn't take any medication that would make your blood more clottable, which hormones do.
Okay.
Now, comparatively, though, birth control hormones are much riskier and much higher risk for these complications than hormone therapy.
Okay.
So doctors prescribe birth control willy-nilly.
They were. I remember my mom being on it.
PCOS, here's some birth control. That's like the way.
Yeah. I remember my mom being on it during her menopause. She was on birth control. Yeah.
But when you compare birth control side to side with hormone therapy, especially the hormone therapy we're using these days, which is bioidentical, meaning that when we say bioidentical, it means that the hormones we're giving you are identical to what your body would create on its own if it was still creating them in adequate amounts.
Okay.
So that means for your estrogens, that means you're getting estradiol or estriol or estrone, which are 3 types of estrogens. And you're getting progesterone, not a progestin, which is actually a synthetic version of progesterone. So like the birth control pills, if you look at them, they have ethinyl estradiol. They're like isomers, if you remember from like high school chemistry. They're different manipulations of these hormones, but they're not the same as what our body would create. So our body tends to take the bioidentical hormones much easier because it's used to these compounds. It used to make them, and so we're giving it something that it no longer makes it on its own. So when you compare birth control with hormone therapy, we can use lower doses. The risk profiles are much lower compared to birth control. So in general, if you're over 50 and you're needing treatment, you should be put on hormone therapy. It's much safer than a birth control pill. But a lot of doctors will prescribe birth control because they just feel more comfortable with it. They've been using it for years to prevent pregnancy.
Sure.
And so it's much easier. They have like more knowledge base with it, but it's not the best treatment for these symptoms.
It's like a lot of people that prescribe metformin instead of GLP-1s. It's like,
yes,
right? Like metformin has horrible side effects, Yeah.
Yes.
We talked to a doctor, Matt Endo, Dr. Young, right? Matt Endo.
Oh, yeah, Dr. Young.
She said during there was the trials, it was the trials they studied on women who were post they were menopausal. And that's where I think where the studies came out and said that HRT was causing cancer, maybe because it was too far advanced in their menopause phase. Is that?
Like the Women's Health Initiative, that was the big thing is that they were treating women much older than what we would consider safe to start hormone replacement therapy. Like really the window of time is that you should be starting treatment within 10 years of your menopause transition. And it's actually more beneficial. Like another one of the big fallacies out there that a lot of doctors subscribe to is that they really shouldn't give you hormones until you're done, right? Until you've actually completed menopause, which is horrible because that means you've been suffering for a decade without any help.
It's a long time.
And then they're finally willing to prescribe. But actually, we're finding that women do much better. They actually have better quality of life, improved cardiovascular health and fitness if you start the medication when their symptoms are most bothersome, which is usually in perimenopause, not when they've completed menopause. Yeah.
Absolutely.
So
that's great. Speaking of other therapies, we've talked to some people about testosterone and is it Osphena?
Mm-hmm.
Could we chat about those?
Sure.
Okay.
So I think that not a lot of women realize that testosterone is one of the hormones that their body actually has inherently and creates on its own. And so, as we're going through this transition and our hormone levels are dropping, our testosterone is dropping as well. And that contributes to our loss of muscle mass. So in midlife and after, we lose muscle at an alarming rate as women. And we lose our bone strength too. And so testosterone is important for those. But the hard part is testosterone is still not FDA approved in this country to be treated for women, for women to be treated with. It's traditionally been prescribed to men. Bodybuilders and athletes have used it as like a performance enhancing drug for years because it makes them run harder, lift more, do all that kind of stuff. And I saw it a lot when I was in the military because I would be treating wives of soldiers and the soldiers were taking testosterone to be able to like be tougher and, run harder, run faster. But then what happened is when they took testosterone at such high levels, their body wasn't creating it normally anymore. And so they were having trouble getting pregnant. But anyway, that's a tangent. Yeah. So we at Winona, we prescribe a DHEA supplement. So we don't prescribe testosterone right off the bat, like from our site, because it's a controlled substance in many states, because it can be abused, widely abused. So, but DHEA is a precursor hormone that our body makes that when metabolized by the body gets broken down into testosterone and estrogen. So it's a gentle way to increase your testosterone levels without giving you testosterone directly.
Quick pause here. I've had moments on my GLP-1 journey where insurance changes or rising costs force me to look for a new provider. And honestly, that process can feel very overwhelming. But that's why the Plus Sides podcast is partnered with GLP Winner to give our subscribers a resource to help them make that decision easier. GLP Winner is a comparison platform that lets you explore telehealth providers in all 50 states, whether you're looking for brand name medications or compounded options. You can see pricing up front, read reviews, and get a clear picture of which provider might align best with your needs. Check it out today at glpwinner.com/plus-sides. That's glpwinner.com/plus-sides. Don't forget the Z. Let me tell you a quick story. I was telling Kat how I was regaining weight after my 100-pound loss using GLP-1 medications, and I was having snacky cravings and waking up at 3 a.m., and I had hot flashes, and I was worried. But Kat was like, listen, I went through this last year. It's perimenopause, and I started HRT, and she used this company called Winona. So I started going there to see if this was something that was going with me. Turns out it was, because I'm 46. And it's been amazing. It's taken a while to find the right dose, but once I did, it's just been huge. I've been sleeping. I feel more myself again. And the hot flashes are gone, which is, really bad. So I will tell you, it's just been so big for me. And so I wanted to partner with them on the podcast because obviously many of our listeners are going through the same age range and definitely are having these issues. And there's just no need for you to suffer. So if you go to the link that's in our link tree, you can click on that and save money. If you go there and you meet all the criteria, this might be something for you to try. So I just want to make sure you had this great resource because it's just been such a big difference for me and Kat. Again, you can go to the link in our link tree and get what you need.
"20 seconds a week to lose 20% of your weight in a year with diet and exercise. That's the power of GLP-1s through Ro. Ro helps find the medication that's right for you, based on cost, availability, and your weight loss goals. Losing weight with GLP-1s is possible through Ro.
Can we talk a little bit more on DHEA? Because you mentioned it on your ads. Like people ask, does DHEA give you, what does it give you, like medical issues or health problems?
Right.
That. Let's let's get real nerdy on DHEA.
Yeah. Yeah. So it's a precursor hormone that's made by our adrenal glands, which are the little glands that sit on top of our kidneys. And it's an important, precursor hormone that's important to those, transitions to those hormones. Now, for patients that have PCOS, they may have had issues. Like sometimes we would run labs when we're trying to work somebody up for PCOS, and we would check a DHEA sulfate, which would be very, very high. Because the main issue with PCOS is that your body doesn't know the normal transition and fluctuations of hormones. And so you build an excess of estrogen and testosterone in your body. And so some women will have really elevated DHEA levels too. And so that's something that we see with that. But the one important thing that women with PCOS should know is that as they age and as their ovary ages as well, their physiology changes. And those mismatch of hormones and the miscommunication of hormones that caused all their issues with PCOS will start to go away as they get into the menopause transition. Wow. So even though they may have had excess estrogen most of their life, as they lose all their eggs and as the ovary ages, they're going to also have low estrogen as well. It's not something that continues into that menopause phase.
Wow.
That's consider for you, Kim, because I know you have PCOS.
Yeah. I think I remember too, like when things started to like regulate with my body too, like I used to have so much hair like all over my chin, and like having that go away was like such a big deal. I still have the random ones, but like it was like thick, like, like, and there's not a lot you can do, like, and
that's actually a common symptom for perimenopause for women that didn't deal with that earlier in life. Like, I always joke, like you might see a woman in midlife, like doing this and you think she's deep in thought, but actually no. She's
a little hair.
I have a gray one. I have one that sticks out here and here, but there's a gray one like right here.
Sometimes they grow because now you can't see.
Like, why does that be gray?
Like sometimes mine will grow so long and they'll be like a curl and it'll be like this long before I even be like, oh, okay. I didn't even notice it.
We're in deep thought.
Where it is. And
we're in deep thought. Well, all rubbing our chins like the thinker, right?
I have a tweezer in my car because it's the best place to catch it when the sunlight is in the car. Because like it's harder to do at home in the mirror, but like I do. So I'll be like, and I don't see this. I must not care about what everybody thinks about me because I will pull that tweezer out in my car and grab that sucker.
There you go.
I will. I'll do it.
Yeah.
We're getting there. I'm getting there. Right, care less. We'll get there with apparently in 10 years. I don't know. Yeah. I know you were talking a little bit about like about kind of what we thought in the past around these hormones and what they caused and but like what are they saying now? Like about if you treat this in terms of like heart and stroke and stuff, can that help prevent that if you're doing this HRT?
Yes. And so the big thing is, when we look at medications and we look at women taking hormone replacement therapy compared to women that don't, women tend to lead a better quality of life. They tend to have overall better health and fitness
I feel it already.
when they're on hormone therapy compared to women that are not. Also, women that are on hormone therapy have a less rapid decline in their vitality, right? So, one of the worst things to see is like that little old woman with the hump on her back who's like falling or broken a hip or, something like that, getting osteoporosis. Keeping our estrogen levels good helps to prevent that and helps to keep our bones healthy. But also, more women actually die from cardiovascular disease and heart attacks than ever die of breast cancer. Wow. And a lot of women are afraid to go on hormone therapy because they have this misconception that if they go on hormones, they're going to get breast cancer.
Yes.
Yep. Mm-hmm.
But they're more likely to die of a heart attack, and you just don't hear about it in the media as much. It's like so many women are afraid of breast cancer, but when you look at the overall rates of breast cancer, they don't realize that they're much higher risk as their heart health. And for us as women, if we were to go to an emergency room with chest pain and with classic symptoms, we're much more likely to be told we're stressed out or that maybe it's indigestion and to not get an appropriate cardiac workup.
Right.
So that's why women have such bad outcomes from heart disease. But if you actually start hormone therapy and you have estrogen levels that are good, it helps to keep those blood vessels that are feeding your heart much more healthy, much more elastic. The heart muscle itself will stay healthier over time.
Yeah.
When you're on, estrogen compared to not. And so there's so many health benefits. And I think we're learning more and more about them each day.
Yeah.
But like back when I was a resident learning how to be an OBGYN physician, they used to teach us, well, this hormone therapy, you'll memorize it for the test. You're never going to use it because women don't want to take it because it's too risky.
Yeah.
But they used to always tell us, like, if a woman demands it, you do the lowest dose for the shortest duration of time possible.
Yeah.
Well, now that I'm an OBGYN who's actually in the thick of it and going through it, you're going to have to pry the estrogen out of my cold, dead hands. Like,
I agree.
I don't want to give it up.
Yeah.
Yeah.
Yeah, for sure. I think it's so different. And I think that's one thing I've learned, like being on a GLP-1 too, is like anytime you take anything, you do have to weigh the risk versus reward, right? So like when people will come into like my lives or something and be like, oh, I'm so scared of all the things in the land. I'm like, look, ultimately, if you've got medullary thyroid cancer, maybe you don't want to do it, right? Or maybe, you might die of a heart attack or obesity or all these other things because you have it, and maybe it's worth it because they've only found it in rats that were taking this, or something like that. Like, I just think that, and just like you said, like the media just blows it up. Oh my God. So on IG the other day, someone sends me this message, this guy who I don't think is a doctor, but sort of is dressing like he's scrubbish, and he was like, listen, we are getting reports now of 3 years after being on these GLPs that these people are having exploding breast cancer. I'm like, exploding breast cancer? What is that? Like, it's just like, guess I better get tested. But like, there's so much crap like that out there to scare people from getting
like
care.
fear mongering. It really is.
Like, your annual mammogram. I don't see how it explode, but okay.
I know. I was like,
I think ultimately it's about like, it's risk versus reward. And I think that, we as patients have to always weigh the risks and the benefits. But, when patients come in and they're suffering from symptoms, but then they're so scared that they're afraid to take the medication. What my counseling is, there is no medication without risk. There's no vitamin or mineral supplement that you could take over the counter that's without risk. Even Tylenol, which we think is one of the safest medications out there, can cause harm if you take it in the wrong way, right? And so many people are so willing to buy that off the shelf and take it, when they have a headache or a fever or whatever. But you can have real damage done to your body from Tylenol. Right. Exactly.
Tear up your liver. Right. Yeah.
Exactly. There is no medication and no treatment without risk, but that we as the patient have to weigh the risks and benefits. And it's like, how much are you suffering? And is the reward worth the risk? And if it is, then you proceed, and that's something that each of us have to make a decision about. But like the other conditions that, that we talked about earlier, like the blood clots in the leg or the lung, or if you've personally had a heart attack, or if you have a medical condition that makes you sedentary and you're at much higher risk for blood clots to the point where they have put you on blood thinners to prevent them, then you probably don't want to take a medication that's going to increase your risk. And I don't think we got to the Osphena. You asked about that too. Yeah. So Osphena is one of the special medications we call a SERM. It's a selective estrogen reuptake modulator. So basically, it's not an estrogen. It doesn't replace hormone therapy, but it basically changes the way your body uses estrogen. And it can have positive effects in certain parts of the body and negative effects, help to block estrogen. Like, it basically helps to boost estrogen in certain tissues and block estrogen in other tissues.
Wow, really?
Yes. So I personally haven't prescribed it very much, just because it wasn't really available when I was more in the in-person office setting. Now I work on Winona, doing the telemedicine for hormone therapy, but I also still work in a hospital doing obstetrics mainly. So I'm an OB laborist. So I do a lot of deliveries and emergency things, catching babies. So I have the two different scopes of my practice, but I'm not in an office doing like outpatient GYN, like in an office regularly. So, if I was, I would probably be using that a lot more, but a lot of women are starting to take Osphena for the vaginal dryness, to help with sexual health, basically.
Yeah. And that's an oral thing that you take?
Yes.
Oral pill. Okay.
But there's other options too. Like there's so many options out there.
Can we talk about them?
Yeah. I think
that
the important thing is that that there are things out there, Yeah.
Why would someone choose to do like, so for example, I do the cream, but Kat does a pill. Why would someone choose maybe a cream, a pill, or a patch? Like, is there any difference in maybe how like people like tolerate that? Like, is it possible that I could do a cream and it's not consistent enough for me, so maybe a patch is better? Or like, are there reasons for that? Because like I was like, you never know like what to choose other than budget, right? Which actually it's quite affordable. Like, by the way, heads up, friends, I just want to say, hormone replacement therapy is nowhere near as expensive as like I feel like we think that is in our head. Like Winona has very affordable options. Like they really do.
And if you have FSA and HSA, I'm saying
yes.
Yeah.
Yes, definitely.
Great.
But no, I think it's more about what you can fit into your lifestyle the best, right? So if you're someone that takes a few other pills and you've already been doing it and you have your schedule and like you remember them, you can just add that pill into the mix.
Yeah.
However, if you're not someone who takes medication regularly and you don't think you'll remember it every day, maybe someone would do better with a patch. You know, and it's really about lifestyle and what you think you can fit into your routine. Because I might think the patch is the best and the greatest.
Yeah.
But if you have had issues with like Band-Aids making your skin irritated, or when you go to get your blood drawn, if that tape they put on irritates the crap out of your skin and you get a rash from it, then a patch isn't the great option for you.
Yeah.
The other thing is with the creams and gels and things like that. So when you're rubbing in those hormones, typically we counsel patients that once it's dry, once it's rubbed in, it should be good. But pets actually, if they rub up against you or they lick on you, like my dog and cats do, they can get a little bit of the hormone. And so maybe
that's why my dog's been such a bitch. Everybody's laughing because my dog does cameos on the show.
Oh, nice.
Yeah, and she
Dr. Cat's dog behind. I saw your puppy.
Oh yeah, my dog was walking back and forth. I wonder who I'm talking to. You know,
like what you got there.
Yeah, it's funny. I'm surprised that one of my cats hasn't walked across and put their butt on the camera because they love to do that when someone's doing that.
They would do both in here.
They love doing that. Yeah,
we talk about butts all the time because Kat does strength training with me on the podcast. So we call it butt stuff. We do butt stuff to keep from losing muscle.
Yes, there we go.
It's a beneficial habit.
There's a lot of butts here. Yeah.
Nice.
In terms of like strength training and that, so we talk about doing that a lot with weight loss, and because we want to be able to like have muscle mass and all things, and when we get older. But like, how does that play a role with perimenopause and menopause?
It's so important. And I think that one of the biggest things, doing some kind of resistance exercise or weight training, moving our bodies is so very important to maintain our strength and vitality, but also to maintain our bone health too. Because once we lose that integral estrogen that our body was creating on its own, our bone health starts to decline, our muscle mass starts to decline. One of the other big things I think that not a lot of women realize is that in menopause and after, we need so much more protein in our diet than we ever realized before, or that we ever needed it early on. And that's also something super important when you're on a GLP-1 too. Because I've seen people do GLP-1s and then just nibble on all the wrong types of foods and become very weak and then struggle with the constipation and do all those things. But you need to make sure you're getting lots of fiber, and you need to make sure that you're getting lots of protein in your diet to maintain that muscle health. Those are so very important. And even myself, like when I started looking up for my height, I'm 5'8", what kind of protein goal I needed to hit every day. I was blown away when I started tracking, and like the days I would do a food log to see exactly what macros I was getting in. I was getting maybe half of what I needed. My protein goal for fat loss and muscle maintenance, just to maintain the muscle I have, is 120 grams of protein.
Oh my gosh.
Yeah.
I'm lucky if I get 90, and I really try. Like I hammer stuff
back.
back.
Like 5'9".
Yeah.
I'm calling Kim out.
So I've had to get like protein shakes and protein bars. I buy alternative protein snacks. I found protein pretzels at Costco and all kinds of things. I'm constantly trying to sneak protein in. And the good thing is like I'm getting my kids to eat it too. So they get more protein.
Yeah, my Kat does Cooking with Kat on our channel, and so she'll do like protein recipes.
I got an idea.
People, like squeeze it in. You know,
nice.
You said pretzels. I have an idea. I'm going to do something. I'm thinking about it.
I
love pretzels, but I can't. I mean, normally having pretzels is nothing but like sodium and flour. So,
right.
I got an idea. I'm cooking it up. Anyway.
Nice.
Yeah, Dr. Cat.
Can we talk a little bit about like when you're trying to find the right dose and things like that, and how that works, and how, like, even maybe how it works in traditional medicine, like if you're not going Winona, and then maybe how Winona does it and how they're different, or just so we can kind of understand, so people know what's a starting point. Like, do they want to talk to a regular doctor? How do they ask? How do you even ask to have this conversation, right? Like, to where you think a doctor will be receptive? Because I don't think there's a lot of doctors that are like, do you want to treat your perimenopause? Like, I feel like, just like you said, like most doctors, that's not even, it's never been a discussion for me. They never bring it. Yeah.
And I don't think it will be unless you're going to someone who, is a self-proclaimed menopause specialist who, like, that's the sole purpose of your visit.
Yeah.
I think when you're going to a regular doctor, it's not going to be brought up unless you bring it up. Yeah. So be that squeaky wheel and bring it up. Yeah. But I think that traditionally, for many of us, that it's safer to start low dose and to titrate up as we need to, because, we took that oath as doctors to first do no harm, right? So we'd rather start low and adjust as we need to get your symptoms under better control. And so that's usually how most people will do. And when it comes to any medications, no matter what specialty a doctor is, they tend to get this kind of repertoire of medications that they get comfortable with, that they use a lot, that they feel comfortable tweaking, and they kind of stick with those.
For sure. Yeah.
And when a new latest, greatest medication comes out, I like to let somebody else guinea pig on their patients with it. I wait until there's been some studies published, because I just don't want to put somebody through the, ups and downs. But I usually, we start patients low and then adjust. But then we have an algorithm at Winona that we use, that we take into account like somebody's BMI, their age, and then we look at their symptom profile to see what cocktail of meds would work best. Yeah. And then combine that with what they think their preferred method of treatment would be, whether it be something topical or a pill. And that's something that the benefits of doing topical, like a patch or a cream or a gel, compared to a pill, is that you bypass what we call the first pass by the liver. So typically when we take a pill, it has to be metabolized and broken down by your stomach. It gets to the liver for processing, and then the liver kind of breaks it down before it gets to the intestines, before it gets processed. And so, if you've had any liver issues in the past, doing a topical medication helps you to bypass that first pass so that there's less impact on the liver compared to like an oral pill. Also, topical, it gets right into the bloodstream through those small little blood vessels in your skin, compared to having to go through the whole GI tract too. Yeah. So one of the big things I've noticed with patients on GLP-1s, what does it do to our GI tract? It slows down our transit times, right? Yeah. So you might actually do better with a topical or a transdermal method if you're on a GLP-1. The other thing that's important too, if the patient's ever had a gastric bypass or any kind of alteration in their stomach anatomy, pills might not be a great option, because their stomach doesn't work to process things as well as a normal stomach would. Yeah. So that's another thing to take into account too.
Love that.
Yeah.
Yeah.
Honestly, it's really like, the way I describe it to patients is kind of like trying on clothes, right? Every woman's different. Everyone likes a different cut, a different style, a different shape. Like, you can't take jeans off the rack and it fits everybody, unless you're in the sisterhood of the traveling pants, right? Right.
Right.
But so it's really, there is some trial and error involved. And so, sometimes we might need to tweak things. And I think that's frustrating for some patients, because it's not like you can just get a medication like right off the shelf that's going to work for you right off the bat. Not everyone. And sometimes we get lucky. Sometimes we try something and women get back to me and they say, I feel great. This is wonderful. Thank you so much. And it's great when that happens, but it's rare that we don't have to tweak the dose here or there.
Yeah.
But I think, go ahead.
If you're going to like your regular doctor, would you say, hey, I think I'm having perimenopause. Is there a test for it that people would need to go through normally?
No. And that's the other thing too, is that if someone is forcing you to go through hormonal testing, you can advocate for yourself and let them know that hormone testing is not necessary. Right. So the downside to perimenopause is that we may be suffering from all these symptoms and starting to have hot flashes and not sleeping well and starting to have night sweats and having all the other symptoms we mentioned earlier. But then if you go to get a blood test done, the blood test can vary. Our hormone levels can vary from time to day based on whether we've eaten, whether we've not. And on the day that you go to get your one blood test, 9 times out of 10, it'll come back normal, even though you feel like shit.
Crazy.
Yes.
Yeah.
So if you look at ACOG, which is the American College of OBGYN, or the North American Menopause Society, which is now, I think, just renamed the Menopause Society, they recommend against routine hormone testing.
Wow.
Yeah.
So interesting.
So it's not needed. So the better thing to do is actually to start logging your symptoms or to do a symptom tracker quiz. So we have a free one available on our website. Like if someone just Googles, Winona symptom tracker, it would come up on the website. And also there's a lot of like really free information and articles that are educational that we've curated that are all free to access on our website too, that people can just go to read and learn. But you could get a symptom tracker like that, which will give you like a week or two to start filling out and like marking down like what symptoms you have and what you don't, and take that with you to your doctor and be like, hey, something's going on because look at all this.
Yeah.
It's so much more helpful to us, like when a patient comes to us with data and with information, because if somebody comes in and says, I just don't feel right, but they really can't quantify it or tell me specifically about like what symptoms they're going through, it's hard for me to help, right?
Yeah.
So if they come with a log of symptoms, it's great information. It's so helpful. Yeah.
I think like finding my dose has been, I'm still working it out. I can't decide if it's 1 or if it's 3 or it's 20. Like, I don't even know. Cause I'm doing the cream and then I take the DHA, is that right? Yeah. I will tell you, like, it's been really, I mean, sexual health's been a lot better, obviously. And like, I haven't had, or when I do have hot flashes, if it's like, they're just very fast, like, and they're nowhere near as intense. Like before, I felt like cells were on fire.
Yeah.
Right. And so I sleep a little bit better, but not so much. But then I find cause I still do have a cycle. So, cause that's where the symptoms and the tracking, that's my point with it all. So I'm not trying to get weird. But like, although I do get weird a lot, like my symptoms. So like my cycles were starting to get really far apart, right? One of the symptoms, right? Getting further apart, it was like 35 days, which for me is very long actually. Since I've been on GLP-1s, and I just kind of noticed every month was it was just like a little further out. And then I started having these symptoms actually after I had my gallbladder out. And that's when I started having hot flashes. And when I was like, really just couldn't sleep for shit. Like I just I'm pissed off about it. And then but when I started HRT, I felt so much better very quickly. But then I also noticed that when my period would come around, like right that week of my period, I would have these like doomsday thoughts. Like nothing's worth anything and everything's on fire and but I would recognize them and go, nothing's wrong with you. What the hell is wrong with you? Nothing's like, you're fine, not aside from the news. Right. But like, I think that I would just have these things and I don't know why. So it's like, how are you tolerating them? So I think that's what's so cool about having the chat feature is that I can send my doctor a message and be like, this is weird. What do I do?
But honestly, like if you're having those symptoms around your cycle, it's because of the hormonal fluctuations that are happening inherently in your own body related to your menstrual cycle. So if you're still having cycles, your body is still creating its own estrogen and progesterone. It may not be in adequate amounts, but there's still like, there's a menstrual diagram that we all have to memorize in medical school that tells us like what each hormone is doing at different parts of the month. And so those fluctuations are still happening. And that is what can be contributing to those symptoms. And for some women, they get like the really, really bad PMS or what we call PMDD, the premenstrual dysphoric disorder. Really bad in perimenopause. Like that can get really exacerbated for a lot of women.
I have a question for you about that.
Does HRT help with that? Like if you can get the right dose?
Yes, it does.
So would you change your dose at all during your cycle? Is that something that doctors will do?
Sometimes we can. Like, so I've had patients who have really bad, like that week leading up to their period is really bad. And if they're on the cream, sometimes I'll say, well, okay, let's add in an extra pump that week. Okay. To just kind of help kind of give your body a boost.
That might help you too.
Yeah. We've been trying to figure it out, but it's great that we're always trying though. Like that's what's so cool, like,
yes. Yeah. Well, and that's the thing is that we constantly have to try to tweak and to make changes to get you feeling your best.
Yeah. I love it.
Yeah.
So Kim is still getting hers, like her normal monthly, greeting and friend. I am in full period. I think it was maybe February or March, the last time I had my visit. But Kim and I were chatting about this before we talked with you, before you came on. My biggest gripe with being in perimenopause is that you get this I always got this like ravenous appetite before my period would arrive, right? I still get it. And it's like the never ending story. Like it doesn't stop. Um, that it does this make sense? Am I making
Do
sense
you
here?
have like specific cravings?
Carbohydrates. I want
Yeah.
all the carbs. Usually it's not like so much the sweets. I need breads and pastas, potatoes. But there'll be like ebbs and flows. But I know that there's no visitor coming for the appetite to completely die like it used to. It just stays there. It's like the never ending story. um,
In all fairness, Kat, you also exercise like 5 or 6 days a week.
yeah, right. It goes in ebbs and flows. And HRT really has helped. It has helped that appetite like going like all over the place. But I wonder if that's just like part of perimenopause. Is that part of the game? And will I see it eventually kind of maybe subside as we go along? Or do I have to adjust my dosage or HRT or speak with my practitioner with Winona about those ebbs and flows and the premenstrual appetite that never goes away?
It could be. I mean, it's not something that's like, ubiquitous for every patient. Not everyone will go through that. But this, could be your body's own individual response to those hormone changes. So maybe altering your dose would help. And I think that the hard part is if you have specific cravings for certain things, like we know that if you don't oblige those cravings, they're just going to go on and on and on and on and on.
Yeah.
If your body wants a carb and you keep giving it protein, it's going to keep wanting carbs.
Or like maybe fake it out, Maybe I'll try to have, what is it, protein pretzels you mentioned. I am fixated on that. What you said, the protein pretzels.
You want carbs.
I found a couple different kinds. I found these like this box of little bags of protein pretzels that are made with like chickpea and cassava flour instead of regular flour, which is how it gets extra protein. But yeah, there's some that taste good and some that are like, they need a dip or something with them. But
Okay.
But yeah, there's more options now. I mean, we certainly have a lot more options to get stuff like that in now than they did a decade ago, for sure.
So, okay. So more or less, basically, I could talk to my practitioner about, let's take a look at our my dosage. Maybe like what Kim said, maybe it's just from, it's still the natural ebb and flow of workouts.
It could be.
Yeah,
it could be. But yeah, if you can, like, if you marked it on a calendar and it always tend to be the same week,
that's where it's. Yeah,
there we go. I got to start marking
it. Just said, it's a perfect example. It's data, right? Like, so
I need my own data, right?
Yeah. But that's so helpful though, because now we can say, I notice this always happens the week of my period, or like the week right before I'm about to start, or whatever it is.
Right.
And then, and being able to adjust accordingly. Because just like you said, your hormones are still, especially if you still have a cycle, because Kat, even though hers don't come very often, it still comes. Right. So, and I think it makes sense, and maybe pay attention to that too, Kat. This is another data point. I love
Sometimes twice a month. Those months sucked.
That's way too much bleeding.
Yeah.
Tired.
Like so many things. I wanted to make sure that if there's anything that you wanted to share with us. And then I also wanted to ask you, like, if you want to tell people where they can follow you. We will have Winona links and all the things. And we'll have link to the resource session, all of that in the show notes for the podcast if you're listening or you're watching. So we'll have all that. But if Dr. Kat wants to tell us where to follow her, or if there's anything you want to share that you guys have coming up, we would love to hear it.
Sure. No, I think that the big thing is just, learn as much as you can about your body.
Yeah.
I think that we should be sharing this information with our daughters so that then when they get to this point in their life, that it's not like this big shocker and big surprise like we had.
Yeah.
So knowledge is power. Like, help the other women. Like, we need to discuss this. Like, it's not some dirty little secret, and it's not something to be hidden anymore. And I think the more we are talking about it and the more women are demanding better, then what's going to happen is that the tide has to turn and more doctors out there need to be willing to prescribe to help their patients, which is good. So you can find me on Instagram. I have a professional Instagram. It's Dr. Kat OBGYN. And it's a lot of informational stuff, videos. We try to just use it as a platform to help patients and to teach as much as possible. But we do those free Winona webinars. There's all kinds of educational material on there as well. I think that the biggest thing is, eat well, like eat like you love your body, move like you love your body.
Yeah.
We only get one
that.
body, and no matter what size it is, it doesn't matter as long as you treat it well.
Yeah.
And, you do what you can to feel your best. And I think, adding HRT into the mix for a lot of women is a great option. And I think that you just need to learn about this process, and so that you're not suffering in silence.
Yeah, absolutely.
Yeah.
Yeah. There's just no need to. I think that's sort of like what we talk about with GLP-1s too, right? Like there's just no need for people to suffer. Like there's help. Well, let me rephrase, the financial issues, right? With GLP-1s is a whole different thing. But regardless, and access to care is something we fight for. So we're always trying to advocate for that.
Yes.
But I think that it's just important to think like you have to have as much knowledge as possible, so you can walk in a room with a doctor who's definitely, unless you're a doctor, right, or has gone to school a lot longer than you have, and be able to say, this is my body and this is how I understand it. And can you answer these questions? And whether that's you're sending them a message beforehand to let them prepare for when you come in to know what you're going to ask, right? Or whether it's you're able to ask it with them and create that space. I think it's very important, and something that I think is going to be important the rest of our lives. And it's just like we advocate for our kids. It's the same thing for our kids, right?
Yeah.
We do it for ourselves as women. And I think we forget.
Right. And if you get a no answer, or if you're dismissed, don't be afraid to find a new doctor. Don't take no for an answer.
I agree.
Any doctor that is good at what they do and is skilled is never going to feel offended if you go to get a second opinion. Yeah. In fact, if they're doing the right thing for their patients, they would welcome it, because then you're going to get the same answer. But if you're not seen or heard, and if you don't feel heard, go to someone who can. And if you can't find that in person, like for a lot of women, they're in a rural area, they don't have a lot of options for doctors. Yeah. You can come to a place like Winona. There's a lot of other platforms out there too. But we're in, I think, 34 of the 50 states now. So wow. It's a great alternative when you don't have the option of a doctor in person who's willing to prescribe, or maybe you just can't get in and you don't really feel like waiting at the pharmacy. The medications are mailed directly to your house, which is really nice.
Yeah. And they're very affordable. Like they really are. Like I think that was a big thing for me, because I didn't have health insurance. So I'm just glad that I wasn't I don't know why. I just thought it was going to be crazy expensive, but it's really just not.
No.
Yeah.
Not at all.
Yeah. Yay.
And you're worth it.
Yeah, you are. You are. There's the Georgia coming out. Yeah, you are. So this has been such a good conversation. Thank you so much for being on our show and helping us learn about this. We've had a couple conversations with some endos about this kind of high level, but as soon as Kat and I were plunging, we were like, we need to understand this. And so do our people, like our listeners, our watchers, they're going through it too. So I appreciate you contributing to what we consider a movement and talking about this with us.
Absolutely. Thank you so much for having me. It was fun.
Thank you. And next time, we will see you next week. Until then, hasta la pasta. Let me tell you a quick story. I was telling Kat how I was regaining weight after my 100-pound loss using GLP-1 medications, and I was having snacky cravings and waking up at 3 a.m. and I had hot flashes, and I was worried. But Kat was like, listen, I went through this last year. It's perimenopause, and I started HRT, and she used this company called Winona. So I started going there to see if this was something that was going with me. Turns out it was, because I'm 46. And it's been amazing. It's taken a while to find the right dose, but once I did, it's just been huge. I've been sleeping. I feel more myself again. And the hot flashes are gone, which is, really bad. So I will tell you, it's just been so big for me. And so I wanted to partner with them on the podcast, because obviously many of our listeners are going through this same age range and definitely are having these issues. And there's just no need for you to suffer. So if you go to the link that's in our link tree, you can click on that and save money. If you go there and you meet all the criteria, and this might be something for you to try. So I just want to make sure you had this great resource, because it's just been such a big difference for me and Kat. Again, you can go to the link in our link tree and get what you need. Today's episode is brought to you by Ro, a telehealth platform that's changing the game of GLP-1 access. What sets Ro apart? Ro understands the challenges of navigating insurance hurdles and the skyrocketing prices of GLP-1 medications. That's why they specialize in getting insurance approvals for GLP-1s. And if insurance is a barrier, they go a step further by prescribing brand name Zepbound vials for prices close to those of compound GLP-1s. With Ro, you're not just getting a prescription, you're getting a partner in your journey that's helping you access affordable treatment and guiding you every step of the way. Whether it's insurance approvals or cost-effective alternatives, Ro is here to make sure that you get the medication you need. Visit ro.co/plus-sides with a Z today to see how they can help you take control of your weight management journey with affordable, accessible care. That's ro.co/plus-sides with a Z, making healthcare work for you. Check out the link in our show notes for more details.
Are you interested in understanding GLP-1 medications like Ozempic, Wegovy, or Mounjaro? Then join us on the Plus Sides, Cracking the Obesity Code, the groundbreaking podcast helping people change their lives one episode at a time. The Plus Sides podcast is a disruptor. We're breaking down barriers, smashing stereotypes, and sharing inspiring stories that'll leave you feeling informed and empowered. Join us every week to learn from doctors who are specialists around GLP-1 medications like Ozempic, Wegovy, or Mounjaro. They'll provide you with science and facts to validate these incredible stories. But that's not all. We'll also bring you the voices of the GLP-1 Mounjaro TikTok community, real people who face the challenges of obesity-related diseases and disorders and discovered the incredible plus sides of GLP-1 medications. Our episodes are filled with heartwarming stories, laughter, and moments of triumph. You'll connect with our amazing community members who are reclaiming their health and experiencing their fullest lives. Are you ready to embark on a journey of discovery and empowerment? Tune in to the Plus Sides, Cracking the Obesity Code, and together we'll change the narrative around obesity and end the stigma. Subscribe now on YouTube or your favorite podcast platform and join our incredible community. Let's celebrate the plus sides of life together because every story deserves to be heard. Every life deserves to shine, and everyone deserves access to expert knowledge and medication. The Plus Sides Podcast. You're not alone. It's not your fault.